Hi, my name is Phillip Sccheinberg, hematologist in São Paulo, Brazil. I'd like to thank you for the invitation to speak at another IBMFS meeting in India. I almost was able to make it in person, and I didn't go because of COVID, it was because of other reasons. But uh, I wish I was there at the CMC Velour. But anyways, I'm sure we'll have other opportunities. So thank you very much for the invite, George, Biju George, and the organizers who actually put this event together, along with many other hematologists. So I will give two talks, and one of these talks I was talking about predicting in response to immunosuppressive therapy. Although it sounds something easy to do and should be easy to do, we have a lot of data actually that seems to correlate with response to IST, but they have not made it into formal algorithms yet, which is a little bit frustrating because if you look at the algorithm of stem cell transplantation versus IST, it still is what we used 40 years ago, 30 years ago. Even though we've learned a lot more about the disease pathogenesis, and some predictors, they haven't really made it and haven't validated into formal algorithms. So I'll just go through three cases just to give an example of some of the things that we have learned over the years. So this is a 62-year-old male who had a 3-week history of dizziness and fatigue. He noticed some gum bleeding, no comorbidities that were significant. He had hypertension, kidney stones. He was taking calcium channel blocker. He had a family history of cancer on both sides, but nothing that was particularly revealing. He went to the emergency room because of these symptoms. He was anemic. His platelet counts were low. Retics were low. So he has pancytopenia, no PNH flow. LDH was normal. So obviously this correlates with his symptoms. So he got blood and platelets. He was admitted. Felt better. Biopsy was hypocellular. There was some residual lymphocytes and plasma cells. There was no dysplasia, and cytogenetics was normal. So pancytopenia, no dysplasia, normal cytos. A little bit older patient with pancytopenia that improved with transfusions. He had a exome sequencing and a mutation in ASXL1 was detected, and there was no other myeloid-related genes, myeloid neoplasm-related genes that were identified, just XL1. So the question is, does that change his diagnosis? Is this MDS and he's less likely to respond to immunosuppressive therapy? So what should you do? Should you ignore the XL1 and treat with IST? Should you call him MDS because he's not going to respond to IST and transplant him? Look for siblings, HLA-MET siblings. Or should you try immunosuppressive therapy, type the siblings, or registry if he doesn't have any HLA-matched sibling donor, and do an early HSCT if he does not respond by 3 months. Or you wait 6 months after IST in order to make a next decision. So the question is, does these neoplasm-related mutations affect the response to immunosuppressive therapy? And this has been studied now in 2 to 3 large cohorts, and the short answer is no, which was kind of frustrating. We thought that we would be able to find using panels or NGS or large panel sequencing of myeloid-related genes, that you would find patients who would be less likely to respond to IST because they had one of these mutations, TNNP3A, XL1, SRSF2. I mean, these that are commonly seen in MDS or sometimes in myeloid leukemia. And no, you cannot correlate these mutations. There's no correlation. So patients like him could respond to IST just as well as anybody else who does not have XL1 mutation. So the answer is no. So these panels that are being done more and more for bone marrow failure syndromes and other diseases, at least in marrow failure, in aplastic anemia, you cannot use this information in isolation in order to make a decision. There's no algorithm that includes that. Oh, if you find a myeloid neoplasm related gene in aplastic anemia, you should transplant. You should not give IST. No, that's not the case. By the contrary, these patients actually respond to immunosuppressive therapy just as well. So this is a part of the uh, uh, prediction that we thought that we were able to find, and yeah, which is actually good in a way because it's negative data, but it's important negative data because some people actually would call if the person is not too informed. Oh, would found this gene MDS transplant. I've seen that happen, and that's dangerous. So no, you should not use this gene finding in isolation. If you detected other myeloid-related genes, the same thing. So you'd have to have a lot of things happening here for you to consider this. You'd have to have dysplasia. You would have to have um, probably a combination of several genes, and I'm going to show you that in a slide later on. But just these genes like this, because we've had patients with DNMT3A who've responded to IST, they were in their 70s, went into their 80s, getting cyclosporin, and they responded, they relapsed. So they didn't develop MDS, they didn't develop high-risk MDS, they didn't develop acute myeloid leukemia, and they did respond to immunosuppressive therapy. And this was a large study published in 2016 in the New England Journal, but others have actually looked at this as retrospectively as well. And this is the RACE trial, actually, which was just published in January 6, 2022, which they did look at mutations, comparing horse ATG cyclosporin versus horse ATG cyclosporin trombopag. And again, there is no correlation between the finding of these mutations, at least in response to immunosuppressive therapy, and there was no difference in the expansion of these mutant clones, preferentially in the Oltromopag arm. That was not the case, actually. It was actually the contrary. And these, you can see here on top, they expand after IST. They didn't seem to impact the response to IST. So this is a prospective study. We'll learn more about it as we see more data, but I'm going to show you later on large retrospective data just showing the same thing. So mutational analysis in isolation alone does not seem to be the answer. Now let's look at something different. 22-year-old female, bruising, plays hockey, very active, fatigue. She passed out on a hockey game. She felt lightheaded, had no seizures, was not post-ictal. She was alert, communicative, so she didn't have a seizure. She had no past medical history except for an appendectomy at age 8, no medications. She had an aunt who had myelodysplastic syndrome from the father's side, and she had a grandfather from the father's side as well who died of chronic emphysema and was a non-smoker. Now, these are red flags for possibility of a patient having a telomere-related disorders. So personal or family history of a bone marrow failure disorder or a pulmonary fibrosis disorder, especially without any history of smoking, or cirrhosis or liver disorder without any drinking history, or hepatitis, viral hepatitis, should raise a red flag. I actually saw a patient just last week who had moderate pancytopenia and has a history of the father having died of cirrhosis without having had a history of drinking. And also from the father's side, there was a sister who had a history of myelodysplasia. So and this person had early gray of their hair. So I said, look, there's a good chance that you may have what? A short telomere, telomeropathy. So these are the counts. Hemoglobin 8.5, as you can see here. I'm not going to read one by one, but counts are not that terrible, actually. And this is what we see with telomeropathy patients. They usually have moderate pancytopenia with a long history. So we spoke about myeloid neoplasm-related genes. Now we'll talk about telomerase-related genes. Do they predict response to IST? Moderate pancytopenia, no KNH clone. She was admitted, transfused, felt better, hypocellular marrow, cytos are normal, no dysplasia. Negative test for Fanconi. She had a telomere length measured, and she was pretty short. This is total leukocyte. So she did have a telomeropathy here. and we sequenced it with a third mutation. She's the only child. Father is German, mother was from the Philippines. Um, this was not here, but erythropoietin was tried with no response. Um, so what should you do? Moderate pancytopenia, short telomeres, third mutation. So does that mean that she's not going to respond to IST? No. We've looked at that as well. Patients with short telomeres or mutations in one of the telomerase associated genes, they can respond to IST. That doesn't mean that they do not respond to IST. Now, keep in mind that the penetrance for these telomerase gene mutations can be very variable. So if she had a stigmata, a very strong family history, or or physical findings, probably that would be a higher penetrance, and that make you think more so that this would be more of an impactful gene with very high penetrance. But we looked at this retrospectively in hundreds of patients, and we looked at short telomeres, and we looked at even those who had a telomerase gene mutation, and we saw that patients with TERT responded to IST just as well. Probably patients with TERC respond a little bit less, but again, there's a penetrance variability here. So the question is, given this information of telomeres, should you put her in the registry and just transplant her early, even though she does not have an HLA matched sibling donor? Should you do a 10 out of 10 or an 8 out of 8 if you find that in the registry, or just go for Apple? So how impactful that information should be for you? And we haven't found that to be used to make decision making, and it's not part of any algorithm because the studies have not suggested that this information makes a patient not respond to immunosuppressive. So neoplasm-related mutations, no. Telomere, short telomere, also no. Androgens can be an option. I'm going to show you that in the next few slides because we have seen very good results with androgens in this patient population. If you had detected TERT instead of TERT, probably, again, that wouldn't change much your decision. I don't think I would use that in isolation to justify a higher risk transplant like HAPO, for example, and determine that she's not responding to IST. I would not do that. So that's the answer then. You should not use this information for telomere life, nor the genes associated with the telomere complex when they're mutated in isolation to say that this patient is not going to respond to IST. Now, there's another patient here. Now, what you might do is androgens, because these patients with very short telomeres, or you might associate androgens, you might give androgens because they have moderate pancytopenia. So you may not justify to give intense immunosuppressive therapy. Transplant will be a bit hard because you're offering some mortality risk with somebody who has moderate pancytopenia without getting transfusions or very infrequent transfusions. So that has to be taken into consideration as well. 49 ER chills, stable, history of diabetes control, stent 3 years ago for stable angiogenesis. 49, but pretty comorbid, on aspirin and a beta blocker, little overweight, excellent performance, lawyer, fully active, family history unremarkable. These are his counts. So counts are pretty low, pretty severe. He's admitted he gets heavy antibiotics because of his infection. He improves, E. coli sensitive, hypocellular marrow, no dysplasia, deletion 13q. So not myeloid-related neoplasm genes do correlate, no. Short telomere, no. Does certain cytogenetic abnormalities correlate with response to IST? And for the most part, no. Deletion 13q, trisomy 6, deletion 20, they haven't seemed to correlate with lack of response to IST. And some people don't. Now, these are cytogenetic abnormalities that are associated with MDS, but obviously this patient has aplastic anemia. They say it's hypoplastic MDS, and it becomes this question. There's not a lot of dysplasia. If CD34 is very, very low, less than 0.1%, this patient has probably aplastic anemia with a deletion 13q, which is what Some people would call it classical deletion 13q and respond just as well to IST. The only exception I would make in terms of cytogenetics would be monosomy 7. And monosomy 7, we know that these patients are a different group, different category. They tend not to respond to IST. Actually, they have a high propensity to evolve to high risk MDS and leukemia. But that's not 100% of the cases, but that's in the majority of the cases. There might be other alterations associated with the monosomy 7 that might make this patient higher, more likely to do poorly. But I've seen patients with monosomy 7 actually not do that badly, but most of them do. So this is a patient you should really look at the transplantation and really not try to insist too much on the IST route because this patient is less likely to respond. But the other abnormalities actually have been shown even in studies that they can respond just as well. These low risk cytogenetic abnormalities. So he diagnosed as you mentioned transplant. Uh, he's not interested. He has had a friend who died of transplant for AML. You consider IST, and the key thing is what to do, right? So you should put for HSCT given the 13q, no. Should you treat it with immunosuppression? Yes. We should treat this patient with immunosuppressive therapy. So having a cytogenetic abnormality like deletion 13q should not make you conclude that this patient is not going to respond to IST. So the question is, can we move beyond age? And that's the thing I've been trying to consider, given that there is a breadth of data now that is coming more and more that seems to help at least predict to some extent response to IST. So you have a 48-year-old male who has a negative DEB test, has a normal telomere length, has a high ARC, positive PNH, has a mutation in PIGA. So these things actually have been associated with response to IST. High retics, presence of PNH clone, PIGA gene or B-core mutation. They actually have been associated with patients doing well with improved survival and no myeloid gene mutations. So, I mean, obviously you have a lot of elements here to suggest that this patient would be a responder to IST and you have nothing negative here. So can we start moving beyond age and try to incorporate some of this information? My concern is that you should not do any of this in isolation in terms of TERT or TERT or telomeres or neoplasm myeloid related genes. Because we know that these cannot, by in and of itself, unless they're associated with other things, be predictive. So this is a slide that reflects this. We're still stuck with age. All right, this is a review we wrote in 2021. And this is we use age and lack of donor, age with presence of donor, age if a child if you get a donor quickly. We still have not incorporated these other things into the initial treatment algorithm to determine if somebody might or may not respond to IST. Age is important for IST, obviously. We know that. Older patients do poorly, but they also do poorly with transplant. Older patients and younger patients do better with transplant. And Andrea Bacigalupo will look at this recently, look at more modern protocols. And again, 40 seems to be a magic number. If you're older than 40, even in recent years, your outcome for having complications related to transplant is higher. You're talking about a 40 to 50% mortality in 2 to 3 years, which is shown here, 53%. And that hasn't changed recently. So age also is a bar predict for related and unrelated bone marrow transplantation. So that's why we use age to give IST, at least in frontline in older patients, especially if they don't have an HLA-matched donor. So age is a powerful predictor, actually. This is a public we published many years ago. I looked at over 316 patients. And as you grow older, your chances of responding to IST actually goes down, around 50 to around 75%. If you're younger. So age is a predictor. These mutations in isolation didn't seem to predict. The largest cohort was actually an NIH study with over 400 patients. And you can see here that in order to get some correlation, you had to lump several genes and in patients less than 60. That only then you were able to start to have some discrimination. But these genes in isolation really did not show in this analysis to be predictive. Now, if you have these genes and you have several of these genes and you don't respond to IST, that's a different story. Because then, that mutation or that finding might have a more dominant impact on that bone marrow more than you you think at diagnosis. We looked at telomere length for response, and we didn't see that to be predictive, but it seemed to be predictive of relapse and clonal evolution. So patients with the longer telomere lengths had a less likelihood of relapsing, and the contrary was also true. And the same was true for clonal evolution. Those patients with very short telomere length had a higher propensity to develop clonal evolution. But this is also interesting because in transplantation, recipients of aplastic anemia for match-related, unrelated transplantation also didn't do too well. They did worse if you had a short telomere, if the recipient. So this is true not only for IST, but also for transplantation. And here's a correlation with survival. So, but it was not, we could not find a correlation with response to IST, which is a topic of discussion today. There are reports lumping together PNH clone and telomere length, especially in children, which seems to be predictive. This is a retrospective study, so I include it here because it's published and the data is out there. So hasn't been validated. But the patients with a very short telomere length, at least in large cohorts, have not been shown to respond less to IST. They might associate with some other things. What we know is that patients with very short telomeres, and this was a prospective study published in 2016, is that if you do have a telomeropathy with a 1% telomere length or a mutation associated with the telomerase complex, you have a 70 to 80, 85% to respond to danazol or androgens. Very high response rate. So it's not predicting response to IST here, but it's predicting response to a therapy. There are some reports that have actually compiled a lot of different parameters that have been studied over the years. Obviously, of course, ATG, a lot of studies correlate that with better results compared to rabbit ATG, but that's a different point. That's not the topic of this talk. But there are a lot of reports actually that have actually shown that a PNH clone actually correlates with response to IST, a higher reticulocyte count, as I mentioned. Not all of them, but there are quite a bit of reports, especially when you use eltrombopag in second line as single agent. ARC was quite correlative. We actually looked at ALC as well, and we found a correlation. Some of these other tests are a little difficult to do, and they're not routinely done in practice. But ARC, ALC, and PNH clones are more routine. And and there's been reports, and this goes along with the mutation in the PEG gene mutation, which is associated with better outcomes. For patients who got eltrombopag as second line as salvage therapy, monotherapy, ARC actually correlated with response. So that's, now this is not correlating with IST, but this is correlating to response to eltrombopag. And in frontline, those patients who got ATG cyclosporin eltrombopag in frontline, many responded. You can see that response rate is close to 85, 90%. So it's very hard to do a correlative analysis because you had very few patients who did not respond to IST. So statistically, there was very little to no power there. But here in this report, interestingly enough, telomere length correlated with response to IST. So Again, this was in supplemental in this paper. So it's an information. It's not entirely clear why that is. You know, you can speculate and you can hypothesize. So myeloid-related neoplasm genes doesn't seem to correlate in isolation. Most cytogenetic abnormalities, when they are present, because the cytogenetics should be normal in aplastic anemia, but sometimes there can be some abnormalities, with the exception of 177, doesn't seem to correlate with uh, response to immunosuppression. Telomere length, again, doesn't seem to correlate universally with response to immunosuppression. CGH, which this data did not show you, does not correlate with the response to immunosuppression. No, there are some other parameters like reticulocyte count, presence of PNH clone, PIG-A, core. No, those seems to associate more to response to immunosuppression. Age seems to be a very powerful still predictor to response to immunosuppression, and probably why that we still have age still in all algorithms that you're going to see for aplastic anemia. So with that, these are my 25 minutes. Here's my email. I wish I had a more conclusive predictor model, et cetera. And it's not for lack of trying, it's just that things doesn't seem to correlate. And that's also important because you don't want a doctor to get one of these pieces of information in isolation and call a patient MDS, conclude that they're not going to respond to ISD, and take them to a transplant when they're 62, especially, you know, that's already a high risk transplant, and especially if they have an alternative donor, just based on the fact that they have a low VAF-XL1 mutation. That should not happen and should not be done. So this is important information as well, all right? Obviously, we like to predict that, but it's so far we haven't been able to get to that point. So thank you very much for the invitation for this symposium, for the organizers, and I'll be happy to answer any questions.